Good afternoon, and welcome back to the Health Leaders, The Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know the most. My name is G. Hatfield, and I'm the CNO editor for Health Leaders, and I will serve today as your moderator for this session. Today's webinar is titled The Winning Edge for Advancing Your Virtual Nursing Program, sponsored by Collette Health. Thank you so much to our sponsor for making today's program possible, and to you and our audience for participating. Before we get started, for those of you participating in our live program, I have a few housekeeping details. Our program will be approximately 60 minutes in length. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all of the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right corner of your screen. Here, we have listed the webinar slide deck for you to download, along with supplemental resources from our sponsor. Additionally, you will find a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists. First, we have Sandy Alexander, who's the Associate Nursing Officer at Vanderbilt University Medical Center. We have Dr. Christine Gall, who is the Chief Nursing Officer at Collette Health. We have Catherine Hughes, who is the Senior Vice President and Chief Nurse Executive at Virtua Health. And last but certainly not least, we have Jennie Van Antwerp, who is the Director of Digital Acute Care Operations at OSF OnCall. So thank you all for joining us. And with that, let's get into our discussion. So according to a recent report, a vast majority of CNOs believe that virtual nursing will become integral to care delivery models in acute patient care, and 38% have already implemented virtual nursing or are in the process of doing so. So I want to get us started first by, can each of you tell me a little bit about you and your organization and also where you're at in your virtual nursing journey? If Catherine, you want to get us started.
Sure, thank you. Good afternoon, everyone. We have launched our virtual nursing care program. We started with a pilot, but we have every intention of rolling that through the entire health system. I'll back up and tell you a little bit about myself first. I'm sorry. I've been the Chief Nurse Executive for about 5 years. Our health system is the largest employer in southern New Jersey. We have 15,000 employees, and we have 5 hospitals and hundreds of other ambulatory settings, physician practices, and other healthcare offerings throughout the area. We began our virtual nurse work with, as I mentioned, a pilot, selecting one hospital and a couple of units to test out how it would work. We're finding great success for us to, improve patient outcomes, improve satisfaction among our nurses, and also a lot of other little benefits that, not little, but other benefits that we didn't plan to see so early on in our journey. So I'll be glad to talk about them as we go through today. Thank you, G.
Absolutely. And Jennie, what about you?
Yeah, so I am Jennie Van Antwerp, and I am the Director of Digital Acute Care Operations for OSF OnCall. OSF OnCall is the digital health entity for OSF, an integrated health system that serves communities in both Illinois and in Michigan. We have over 158 locations, including hospitals, across both of those states. And really, again, just like has already been said, virtual nursing started as a pilot, of course. Back in 2023, we started with just a couple of inpatient units, medical surgical units at St. Francis Medical Center in Peoria, Illinois, our largest facility. And we really collaborated with leadership at that facility, frontline mission partners, employees, that's what we call our employees at the facility, and also within OnCall. And so then we really, in the last 3 to 4 months, have really spread that across most of the medical units at St. Francis Medical Center, as well as the emergency department and our centralized model of virtual nursing, which is out of OSF OnCall. We also have a decentralized model of virtual nursing that is ongoing as well in our ministry that provides an opportunity for virtual nurses, for frontline nurses to work as virtual nurses and at the bedside. And that is currently ongoing at St. Anthony Medical Center in Rockford, Illinois, to give us an opportunity to really understand the difference between both of those models.
Great. And then Sandy, what about you?
Yes, good afternoon, everyone. Sandy Alexander, I'm the Associate Nursing Officer at Vanderbilt University Hospital. That is our academic adult hospital here in Nashville. We have about 2,700 frontline nurses at the adult hospital. We're currently licensed for about 790 beds. We're putting a new tower up that's going to add 180 beds to that 790, so quickly growing. Our journey, we started very similar to others on the phone. We started as a pilot back in July of 2023. We are up to, that pilot was 36 beds. We did it on just a single unit. Quickly saw the value and expanded. We are currently now rolling out our 12th unit this month, and so we'll be at about 350 beds here very quickly. So you'll hear a little bit more. Similar, we have our nurses, our Vanderbilt nurses. We took our admission discharge patient flow nurses and moved them into virtual roles, and then also added additional. We do have some hybrid nurses that work part-time on our virtual nursing team, as well as part-time on their home units where they came from. So enjoy that. We have both sides of that, but that's about it.
Absolutely. And then Christine, what about you?
Thanks, G. I'm Dr. Christine Gall. I'm the Chief Nursing Officer at Collette Health. We are a provider of hardware, software, and professional consultation services for our organization partners across the country who are addressing their journey into virtual care services. And G, I was intrigued by the survey that you quoted. I know that survey well. And of the 30, I think it was 38 or 36% that are of organizations that said that they're working in virtual care and virtual nursing services, only 10% of those respondents actually said that they felt that they had really hardwired it. So this is definitely a top of area interest and concern that we're all working with. So I'm really excited to have this forum to be able to discuss it with some colleagues who've done some great work. So thanks for having us.
Of course, and absolutely, as you're saying, health systems everywhere are at different points in this journey, whether it be like programs in their infancy or 5 years down the line. So I wanted to ask each of you, kind of in a treetop lens, what were your goals for starting these programs, and what should CNOs or other innovation leaders keep in mind as their primary goals for building and implementing a virtual nursing program? If Jennie, you want to start.
Thank you so much. Really looking at what's your primary driver? What are you really looking for and hoping to achieve? And at OSF, we really saw that there was an opportunity to learn from some of the things that we have already done. So we do have virtual intensive care and have had it at OSF for a number of years, which is a higher level acuity form of virtual nursing in some respects, and in others, of course, it is different. And so really understanding what value virtual nursing could bring, not only to the organization, but to patients, patient care, and of course to our bedside healthcare providers. So really looking at where was the opportunity for us? Not to give too much away, of course. Really, our opportunity was looking at our realistic time for admissions and discharges, and then other aspects of care that did it need to be in the hands of those hands-on caregivers at the bedside, or could we leverage what we already knew and had been doing in other aspects at on-call and within OSF to take that off of the plate of those individuals.
Absolutely. Yeah. I think that's a big goal that I've heard from multiple health systems of taking off that administrative burden. So, Sandy, what do you think?
Yeah, so ours is very similar. We really started with virtual nursing at the same time. It was in January of 2023 when we were faced with similar to many a nursing shortage. And so this was really, how are we going to continue to deliver the care that we need to deliver at the bedside with fewer nurses, and getting the same outcomes in the high quality of care that we wanted to deliver. So this was really to help leverage the RN, keep some of our, experienced nurses that were really wanting to head into retirement or decrease their hours that they were working. So how did we keep that knowledge? And then also improving some of our staff efficiencies. And then we were also looking to how do we coach and help those novice nurses at our bedside. And virtual nursing is kind of what was our solution to several of those questions that we were trying to address.
Mm-hmm. Absolutely. And then Catherine, what are your thoughts?
Very similar to the our other panelists, especially what Sandy just mentioned. But I will emphasize that we realized that the workload of our bedside nurses was just growing and growing year after year, and many things were contributing to that. The higher acuity of our hospitalized patients, the rapid turnover of patients that we would get patients in, get them better as quickly as possible, get them discharged as quickly as possible to refill the bed. We face the same nursing shortage issue, the shortage of assistive staff like patient care technicians and other staff that were not always as plentiful as they were in the past. So that whole workload issue was identified as something that we just couldn't continue with our primary nursing model. We had to look at something different. We knew we wouldn't retain nurses much longer, as we had seen in previous decades, that nurses would have this kind of career for their entire professional career. It was just too physically demanding. The workload was too heavy. So that was one reason that we had to look at a different model, that the care model just had to change. I think the other equally important issue was our patient experience. We looked at what our patients and families are expecting from healthcare and from our nursing care. Our outcomes, as good as they could be, could certainly be improved. And we saw lots of opportunity with virtual care, whether that virtual nurse was taking away the administrative tasks or actually helping to improve outcomes by sending reminders about turning patients or helping to teach about medications, anything that would help the patient outcomes to improve. So that whole patient experience part was equally important as the nursing retention and nursing workforce issue.
Absolutely. And then Christine, what do you think? What should CNOs have in mind for this?
As I work with and have conversations across the country, I think starting with the understanding that you really have to look at the culture of your organization and its state of readiness to address the pain points that are top of mind. Leveraging a virtual nursing program really is an important and critical point to consider. Not all organizations, not all units within an organization are at that point where they can lean into a substantial change in nursing workflow. So starting out the selection process with, who could really be that pilot unit that could position us as an organization and as a system for success. I think that's critical. All of the points that have been made are absolutely spot on as well. And I think that ideally, it is so very important that we are working and learning from each other. I said before we started this recording today that in my experience of over 3 decades, I think that the only other time within my professional career where it wasn't a question of if, it was a question of when you were going to implement something was when we initiated the electronic health record. We all knew that it was coming and we had to figure it out. And because of the great information, the great detail that's been provided by my co-panelists, we have an imperative that we have to figure out how to leverage technology differently. So I think, how we do that, how we learn from each other. And I also like to say, just because a pilot doesn't meet all the performance indicators, that doesn't mean a fail. It means that you've learned something that you can iterate on from there. So I think that's important to consider.
Absolutely. It's almost like its own mini industrial revolution for healthcare with all of this new technology coming through. So each of you have mentioned it a little bit already, but I really want to get into the benefits of incorporating virtual nursing into nursing workflows. For our audience watching, according to that same report, 75% of CNOs see virtual nursing as a chance to recruit nurses who are unable or unwilling to work at the bedside, and 59% cited patient discharges as a top use case for virtual nursing. So for each of you, what are some of the hard benefits that you're seeing from these programs? If Sandy, you want to get us started.
Absolutely. So I think you mentioned 2 of it. So recruitment, retention, certainly for our experienced staff. Throughput for us, our discharges, that is one of our metrics that we look at our quality of discharge, but not only that, how quick are we able to turn that discharge around once we receive that discharge order. And then additionally, I think as we kind of are moving through this, it's having that expert nurse be able to help do the coaching and the mentoring. We also have been looking at other ways, and so we have our pharmacy colleagues helping with meds to beds, which is helping facilitate our throughput, as well as just doing some of our safety rounds, which has helped the bedside nurses as the virtual nurses are doing those safety rounds and the good catches that they have identified with that. I think additionally, some of the workflows that we've incorporated in this is just some of our MRI checklists. The virtual nurses are doing predominantly all of our MRI checklists for our units that are live, as well as just answering some postmortem care, dual med sign-offs. We're doing that for our high-risk medications. So we're seeing it in different areas outside of virtual nursing. So really trying to leverage that platform for the next is going to be our case managers.
Absolutely. And then Catherine, what are your thoughts?
I just wanted to emphasize the discharge piece. That is an important focus for us as well. We've identified that we're not always great at that. There are always a lot of distractions at the bedside when the patient is preparing to go home, lots of activity. So having the virtual nurse be able to have a process for that and to be able to loop the family in, even in advance of the discharge, it doesn't have to be at the discharge time, is very helpful. And I think, improving the quality of the information exchange and making sure that patients and families understand how to take care of the patient at home, that's been critical for us. Some of our aftercare programs, we do have a hospital at home program, a care after discharge program, and a home health program in our organization. And the feedback, we're able to, hear the feedback from those nurses telling us the gaps that they find when they get to the patient home, how much the patient didn't learn at their discharge time. So we're working together to improve that discharge process through the virtual nurse. The other part I mentioned a little just with the discharge is that in all parts of the patient care, the virtual nurse is able to easily loop in the family from wherever they are, at least in the model that we have, the equipment or the program that we use. We're able to connect the family into the program, so the family can hear can see and hear at the same time as the patient. So that's really been valuable as well. We don't have to wait for families to arrive at the bedside or try to time things with the physician and the nurse. That's been a big benefit for us.
Mm-hmm. Absolutely. And I feel like that hospital at home part of it, piece of it, is going to really be the next kind of phase of this, for sure. And then Christine, what are you seeing from your vantage point?
Yeah, well, I'd say all of the examples of how virtual nursing can be leveraged are really critical and key. And again, the virtual nursing program that is occurring at Hospital A and System A is going to look very different than elsewhere in the organization, and that's by absolute design. We have to make sure that we're focusing on the pain points that are unique to our specific organizations. But I think that when we talk about the administrative burden and what that means, we need to look at a little bit of a higher level. To me, it's how are we helping the novice nurses learn their craft in a different way? Because I'll tell you, the acuity and the number of touch points that go through nursing that have to, we're kind of the conduit, we're the switchboard that everything goes through. And so when you have that bedside nurse, that's the communication central, in addition to coordinating and doing all of the acute activities that need to happen, having somebody that is one step removed that can actually provide quality, uninterrupted education, work on that discharge planning piece with the patient, with the family members remotely coming in, that offers a higher level of service than that bedside nurse is able to provide. And it's not a testament or a statement on the quality of the bedside nurse. It's simply the way that role is designed. They don't have uninterrupted, dedicated time right now. They have to be able to be multitasking at all times. So having that additional layer of a virtual nurse that can serve the purposes at those mission critical points in the hospitalization is a really valuable tool.
Absolutely. And then Jennie, what are your thoughts?
Yeah, I agree. And we started our pilot primarily with discharges, to be really honest, and then layered in the admission piece, and most recently the med history piece. So when you really look at, what does virtual nursing really bring to that bedside nursing workflow? I would say it's improving expertise in the workflow. Look at all of the pieces of the patient puzzle that you put together on a daily basis at the bedside, and all, again, just as what's been mentioned, all of the hands-on tasks that have to occur. If you can bring that nurse out of that medical record and put someone else in there who can do that work and connect those dots, I'm sure we can all speak to the number of errors that have been found just by having a few extra minutes to see that, that provider didn't order the home insulin in the correct way, or order the home insulin supplies that were needed for the patient, where the virtual nurse was able to have those extra minutes taken back from the bedside nurse to really look and see, hey, they can't go home and give themselves their insulin. So let's get the things that the patient really needs, and then again, elevating that patient experience and really preparing them for discharge and to be at home. On the admission side of things, we can all talk about throughput, I think, especially in this influenza season and respiratory season, and getting patients out of the emergency department and to where they need to go with a timely and accurate admission is always going to serve that quality of patient care and the way that we want to see.
Absolutely. And all of you have mentioned it a little bit, but obviously a huge component of this is the nursing workforce themselves. So how can leaders incorporate nurses in the decision-making process of creating a virtual nursing program? Because obviously you have to do it hand in hand with the people who are going to be using it. So Catherine, what are your thoughts?
Well, first of all, the big decision to bring it into the organization is made, at a higher level. But in order to have nursing buy-in, into the project and to appreciate what it can do for nurses, they absolutely have to be part of the team. We experienced a little bit of caution. Some nurses were worried that this was going to replace their jobs in some way, that this would take over some of the things that they really wanted to do with their patients, which might change staffing, or it might change anything, what their work life would be. So it was important for us to make sure they were part of all of the discussions. We created what we called readiness groups, clinical readiness groups, and nurses were able to give input into workflows, into how we designed all of the aspects of the program. And so there was already, because of that clinical readiness group, they were sort of our champions going out to the patient units and helping others to understand how much benefit they would achieve by adopting this. So they gave us also the feedback we needed for what really happens at the bedside, not just what we think is happening there. So it's very important to have them part of the decision making from the beginning as much as possible. As I mentioned, that's how we got buy-in. It's how we got the real information we needed, and we were also able to answer and reassure people about what this meant for their employment, their role as RNs in the organization.
Absolutely. And I love how you mentioned the groups of nurses who you were educating about it first so that they could take it to the rest of the workforce, because nurses really are the best communicators for that, I think. Yeah. So then, Jennie, what do you think?
Yeah, I'll piggyback on that. I think starting in a couple of units was immensely helpful so that they could get the word out, and they could talk to each other and talk it up and talk about the benefits. But right from the beginning, when we started our pilot, our kickoff included frontline nurses at the facility. So it really, again, taking it back to the nurses that are doing the work, I think leaders, often we see how the work might need to be done or should be done, not always how it is done in real time for a variety of reasons. And it's important for us to get kind of down in the weeds and really understand that, so that, for virtual nursing to be successful and to really meet the facility needs where they're meant to be met at, we have to understand that, or we're going to miss the mark. We're going to miss the nuance of the care that's provided in the facility that we might not completely understand. And really, do they have a discharge lounge that they need to go to? If we don't truly understand the context of where the care is being provided, then we're going to miss that. So I think leveraging our nurses at the very beginning, and then our development and implementation teams, they were in the facility during go live, helping the nurses take tablets to the rooms, troubleshooting tablets or whatever technology was in use, and answering questions and taking feedback. And then we were doing huddles at shift changes to ensure they had an opportunity to provide their voice. And then follow up stoplight reporting to ensure that we were following up with them.
Absolutely. And then Christine, what are your thoughts?
Well, definitely identifying staff champions who they will have probably the greatest impact on their work colleagues. But when you're thinking about configuring those multidisciplinary teams of the folks that will either use the new workflows or are going to be impacted substantially by those workflows, including physicians or other disciplines, it's really important to think about, making sure that you are taking the staff nurse who is not afraid of technology, who is definitely an early adopter, but you also need to think about the other side of the coin, the folks that are bringing you those great arguments that you might not have exactly the right answer for, and it's out there, but they bring up that challenging point. You need to bring them along as well and help guide them, because they will save you in so many ways from my experience. I think the other thing that's really important is to think about how we then take what they've done and how we bring it out to the other groups so that it does the communication plan and how it is launched is seen as grassroots with guidance. I think that's very important. I had the opportunity back in the 90s to work at the pediatric hospital that I was leading at with the CNO and another colleague. And we were, I don't know why, but no travelers like to come to Wisconsin in January. I don't know why. So we had to create our own peak census program. But bringing everybody together, having established the parameters, okay, here's where you can play in, here are the guardrails. And if you need checkpoints, we had a great facilitator who helped us along the way. But every year, and I think that program, even this many years later, is still being evolved and revised every year. I think that's so very important. And that's a unique skill set in itself. In my mind, having the ability to represent not only your own thoughts, but the thoughts of your team requires some development of a skill set. So I think early on, being able to tool the staff that we've handpicked to represent their colleagues, giving them some guidance on how they need to go back and check in and do those, informal focus groups, get buy-in, or say, hey, I didn't think of this, but somebody brought up a great point. And when they brought up the great point, I asked them to give me an alternative. So here's what they said, and bring that back to the group. I think the more richness that comes from spreading the decision-making in multi-directions, the better the outcome will be.
Absolutely. It's all about creating those good feedback loops. Yeah, and then Sandy, what are your thoughts?
Yes, so very similar to what you've heard. I think when we started this, that was what we absolutely did, is we chose the unit that we were going to do our pilot on, and brought a sampling of night shift nurses, day shift nurses, weekend nurses together to really design the workflow for how this could help make their life better. Quickly learned that it's more than just nursing. So it's also our care partners, our nursing assistants, our medical receptionists. It was every aspect of the care team that would be somewhat involved in some of these workflows. So did include them. I would say a big partner that has not been mentioned, or if it has, I missed it, has been our IT partnership. And so this is technology. And so our IT leaders and colleagues have been right next to the nurses as we've kind of implemented, and we certainly could not have done that without them. And so they were part of our go live staffing model. For every unit we brought up, we had our informatics nurses as well as our IT colleagues. I think the other thing that we have learned is that not every unit is identical with the different patient populations that we serve. And so really trying to seek to understand, once we put virtual nursing on that unit, how is that going to change their current workflow, and really try to mitigate any challenges ahead of rollout. So we learned that as we were going live with our second unit so early on. And I think the readiness support group for the go live and the week after go live has been helpful too.
Mm-hmm. Absolutely. And I'm so
might I comment that there is one way of tooling a group of staff. The Academy of Med-Surg Nurses actually offers a certified acute care virtual nurse credential now. And I think that's another, from a professional practice model, I think that's an area that we can invest in and focus on for the next generation of nurses that's going to manage all of this.
Mm-hmm. Absolutely. And Sandy, I'm glad you mentioned the IT partners, because obviously the other half of this conversation is technology. So I wanted to ask all of you today, what advice do you have for deciding what technology to use and what to leave behind, whether it be, like fixed televisions or cameras or all that good stuff? What are your thoughts? And Sandy, I'll throw it back to you.
Sure. So I would say I as a nurse, IT was not my forte going into this. I have certainly learned a lot about technology from my IT friends, but they did their assessment as well as nursing did our assessment when we were choosing what technology we were going to go with, what platform. The one challenge that we went with fixed televisions. and cameras mounted on top of our televisions. We did not use tablets. We had tablets in our semi-private rooms, and those began to be more challenging for us. And so we did stop using those. So all we are currently using is our camera mounted on our TV. It is just technology, and then just teaching. The nurses have done a remarkable job of trying to get our IT project managers that have been working with us of, here's what we need to see, here's what we need to understand, this is what we need access to, and really trying to have them change it into the terms that they need, and get us what we need to do the work. So it's been a good partnership for sure.
Mm-hmm. Absolutely. And Jennie, what are your thoughts?
Pilot. I mean, we say it a lot, right? But understanding just how it's going to work, giving an opportunity to just test it, honestly. And we've done that to a great extent we have two different technologies that we're using right now. We're using tablets, and then we're also using in-room equipment. And we're still exploring what the best fit is going to be for not only for our organization, but for our patient population and for our frontline nurses. So really we have to go through it, right? So that's how nursing goes. That's how nurses are. We like to touch, feel, explore, understand, give feedback, break it, drop it, really understand how it's going to work. And I think that's just a great opportunity in this learning phase. And then we learned a lot from virtual intensive care and the in-room equipment that virtual intensive care has, the type of cameras they have, their abilities, and really leveraging that understanding and information, and as to, do we need that in our med surg environment? I'm going to say yes, of course we do, because that gives us an opportunity to leverage the technology to maybe do more.
Oh, it seems we might have lost Jennie there, but that's okay. We'll keep going.
And help the nurses.
There she is. Okay, well, I think she's having some technical issues. So while we try to get her back, we'll keep moving.
Sorry.
Hello, can you hear us okay? All right, perfect.
Yes, I can. I'm sorry.
No worries at all. Do you want to finish what you were saying?
Left off.
That's okay. All right, well, Catherine, why don't we go to you?
Okay. First of all, we're really lucky. In my organization, we have an Office of Digital Transformation. So those experts were really helpful working with IT to help us look at the vendors that were leading in this area of virtual care. We also leaned heavily on our Chief Nursing Informatics Officer, our CNIO. She was so important to the process because she knew the nursing side of things and could blend that with the technology side. So she was really critical. She was also very knowledgeable about virtual care. She did lots of work on this in her doctoral project. And so we were really blessed to have her expertise added to the project. Along with that, as we looked at the vendors, as someone mentioned, we wanted to practice everything as well. We were looking for something that gave us multiple use cases. How could we use this for nursing, but how could we use it for physician care, for, how could a dietitian use this to talk to a patient? We were looking at all different uses of our, health team. We were also wanted to test it out. We actually had work sessions where we would have, someone lie in a bed. We had a little studio here, and we would have someone lie in a bed, and we would have, the ability for the virtual nurse to zoom in and see, a patient's pupils, that person playing a patient. We could see pupils, we could see IV pumps and what the settings are. And we wanted to test to see how comprehensive is the program, because as we do more and more with virtual care, we won't just stop with admissions and discharges, but we want to look at, what can that virtual nurse see in the room and help to do over time. So we wanted to be able to see that. Can the nurse actually see the IV pump? Can they see the the features of the patient. So we tested all of that. We also had a concern about privacy. Would cameras always be on? Would the patient be worried about being observed 24/7? So we selected a camera that nicely covered that for us. The camera, goes back up to the wall. We have a fixed smart TV. That's the model we chose. Had those installed, and the cameras will rotate back up to the wall so the patient can see that they're not on camera. So lots of those things were part of our considerations that, we wanted to make sure that the program would grow with us as we saw more and more use cases, and that we were able to protect the patient and as well as add more and more capability for the health team.
Absolutely. And then Christine, what are your thoughts on choosing technology?
Well, I appreciate all the comments that have gone into the considerations of my colleagues on the panel in this question. I would add that I think it's important to think about virtual care as a journey. A lot of organizations have started out in virtual observation, which is basically not a nurse, but typically a nursing assistant or somebody with less training that is watching that patient for safety. That's usually 24/7. We've talked extensively about the virtual nursing aspect, and also the expansion of that idea or that use of technology to physician consultants coming in or other providers coming in, and with the goal of streamlining care, reducing delays in care, moving care along the continuum so that patient has, what the 6 dimensions of quality speak to: the timely, the effective, the efficient, centered on the patient and family. All of that is done. And so I think when you're looking at your vendors, obviously you need to create a list of what's important to you based upon your goals for the program. But I also think it's important to look at, what is that partnership going to give you beyond just the technology for a certain cost? You should look for those organizations that have been recognized by their own customers as being, top from the perspective of being a great partner in care, because this is an evolution. Nobody's figured out completely what virtual nursing, what virtual care is looking like. So that means that all members, all organizations that contribute to virtual nursing need to be continually evolving and growing. So that would be what I would recommend. Look at the technology, definitely the features, the ability to scale, and how that matches with what your current and future priorities are.
Absolutely. And speaking of growing and scaling, obviously we have to have ROI metrics for virtual nursing. And I know that looks different for a lot of health systems, depending on the point they're at in their virtual nursing journeys. So with all of this in mind, how do you make the financial case for it and keep the program cost effective? And what kind of metrics are you using? If Jennie, you want to start.
Yeah, let's hope that we don't lose me again. I'm so sorry for that.
No worries at
But
all.
that's how we work in technology, right? We just keep on rolling. So we are
Absolutely.
looking at a variety of different metrics. First and foremost, quality of care, quality of admission, quality of discharge. I think those are all very value added. And as we continue to look at 5-star quality for patients and just overall metrics that we need to meet for patient care, patient experience, really understanding the impact that virtual nursing, once it's leveraged at the beginning of care in the admission and then throughout care through discharge, what impact does that have on the patient experience? And, how can we leverage virtual nursing through the future and continue to improve that experience for our patients? And then nursing engagement, turnover, and retention. We all are facing, for the most part, I would say, shortages in nurses and or types of nurses that we have at the bedside. From novice to expert, we continue to see our expert nurses leaving the bedside. So, how can virtual nursing continue to be leveraged to help with the quality of patient care, but also in retaining nurses to to a bedside function of some respect, to continue to provide that care to our patients and improve their quality. And then as we get into different aspects of virtual nursing, I think we'll continue to leverage what metrics can we associate with maybe the tasks or other inputs that virtual nursing will have at the bedside, and what ROI, soft or hard, will we gain from that?
Absolutely. And Catherine, what are your thoughts?
Exactly as Jennie said, and we're looking at everything, all of the metrics that help us justify, the cost of the program. And, just to mention a couple of others that she didn't mention, the patient outcomes piece, we're looking at a patient falls and how can the virtual care help reduce patient falls. We know that some programs, the program we chose, has an ambient sensor. So we're actually able to monitor a patient. We can discontinue the separate program we have for like a telesitter program, because we can incorporate that into this model once we have everyone live on the virtual care program. So we're able to better prevent our falls, look at some other issues that we might pay extra for extra programs to do, but just the outcomes piece, helping to improve outcomes, will help us to reduce costs that we incur from those negative outcomes. We are sure that improving discharge information and discharge planning will help us to reduce readmissions, another cost savings. And of course, the big workforce piece with retention of our staff, knowing that we're trying to reduce the workload. We're finding other career possibilities for those nurses that can't be or don't want to be at the bedside any longer. So all of those same things are the things that we've used as part of our case for virtual care.
Absolutely. And then Sandy, what about you?
I think very similar to what you've heard. I think the struggle that we had is, how do you really attach the hard financial dollars to this? Because a lot of it is that soft ROI, as Jennie mentioned earlier. So we're definitely looking patient experience, our discharge metrics, and our throughput is part of ours. What we are also looking, and I don't think that has been mentioned, is we're using the technology to schedule our post-discharge follow-up appointments. And so being able to capture that, that rate helps give a little bit of ROI for ours. And then also our readmissions. And so really understanding, since we're not live in all aspects, are looking at our readmissions, what readmissions are coming back that did discharge with a virtual nurse versus not a virtual nurse, and being able to capture some ROI on that as well. And then the soft ones really are those good catches that could have prevented, that prevented harm. And it's just hard to put that dollar amount to that, but it did prevent harm for the organization and for the patient.
Mm-hmm. Absolutely. And then Christine, what are your thoughts on making the case for virtual nursing?
Yeah, so when you're looking at hard numbers for ROI, I think it's important, first with technology, as I spoke of earlier, when you're looking at wanting to transition from just virtual observation into bringing experts to the bedside for episodic care, do you have technology that can walk with you on that journey without any additional need for evaluation of new technology? Do you have that partner that's going to scale with you? That's one piece, I think, that has hard ROI attached to it. A second one would be when you're looking at financial, obviously we want to save dollars financially. The value-based care side of the equation, we've talked about it, fall reduction, unplanned readmissions within 60 or 90 days of a hospital discharge, all of those things that add risk, financial risk to an organization. And when you're able to mitigate or reduce those numbers, you have cost savings. You might not have a revenue stream, but you definitely have saved dollars leaving the organization. Those are things that we have to get, I think, more acute at measuring. The fines associated with falls or with CAUTI or CLABSIs, how are we reducing those? And so we track rates really well in hospitals, but are we also tracking the associated dollars saved? And I think that's important. The balance to that is patient experience. If we save them from getting a hospital-acquired condition, what does that mean in terms of how they feel about us and their interest, and would they recommend us to their family and friends? Those kinds of metrics are important to assess as well, and there are dollars that can be assigned to those. Then last, I think an area that I think we have not been as focused on as I believe we need to in the nursing realm is when we have turnover, we tend to move all of the associated costs with addressing the turnover into another cost center, usually HR, something like that. And in my mind, while definitely we want to track what is happening operationally on our units differently than those other extenuating circumstances, we also need to pull in the dollar amount of, if it's 50, I think the average $56,000 to replace a med-surg nurse, and that goes into six figures when you're talking about a seasoned and specialty nurse. Let's start adding those costs in, and then through our pulse surveys, looking at resilience and employee retention and engagement, really being able to track whether or not what we're doing in automating workflow is translating to those staff feeling that they got their work done, that they felt good about what they did, that they continue to fill their tank. And then lastly, I would just say, when it comes to, we had one of our partner customers did a formal study, and they were looking at virtual observation at the time. And what they were able to demonstrate with statistical significance is that when they were leveraging their observers well for those challenging at-risk patients, the nurses were able to take their lunches, get out on time because their workflows were so positively impacted. They didn't have as much reactivity in their day. And I think that's one of our challenges is demonstrating and pulling all of those factors together in a bow for our financial partners and those folks that are saying, why do we want to pay for this? I think we have to flip the script to we have to not only pay for it, but do it right, because that will come back to us in so many different ways.
Absolutely. Well, I think we could sit here and talk for a whole nother hour on this topic, but unfortunately we are coming up on our time pretty quickly. So thank you all once again for this excellent discussion. And this is now going to bring us to the Q&A portion of our program. So we would now like to invite you to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It might already be open and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. And let's see, this is a good one. In your opinion, what has virtual nursing not been successful at? And maybe you can shed some insights on what you think it can do better. If Sandy, you want to get us started?
Sure. So I think what we have not been able to really do well is those discharges that really have a lot of hands-on teach back. And so if anybody that has solved that, that is one of our challenges. So patients that are going home with devices or that need to do a hands-on teach back, we have not solved that problem from a virtual aspect versus in taking that away from the bedside.
Mm-hmm. And then Catherine, what do you think?
That's probably my answer as well for those complicated patients. And honestly, it seems like the bedside nurses still feel that they have to review a lot of things, even though the discharge nurse has done that virtually. So, it's sort of changing that mindset and the practice. But it's not a bad thing that the bedside nurse is helping to reinforce a few things. So it's just a change to adopt.
Mm-hmm. Absolutely. And Jennie, what are your thoughts?
Yeah, I absolutely agree. I also think depending on how you're providing your virtual nursing service, for instance, we're the digital health entity for OSF, there are nuances that happen on the floor every day, or changes in care, or education, contextual information that might be missed. And so really, closely integrating those changes with the service provider is important. I do think that across the board, we probably have that opportunity in healthcare overall, but have definitely seen that at times in our virtual nursing as well as other virtual programs.
Absolutely. And then Christine, what do you think?
I'd like to go elevate one level to an area that I think is a potential area of challenge just in virtual care, virtual nursing overall, and that is how do you document when you have two nurses, one virtual and one at the bedside, that are both responsible for pieces of the same patient's medical record? How do you ensure that you have completeness but not duplication, that you haven't created gaps, and your workflows are not creating another layer of challenge for either of those groups? So I think figuring out how documentation within the medical record happens, who does what, and that everybody feels comfortable with their role, not to add additional steps to the process of documentation, is a challenge that really needs some incredible consideration.
Absolutely. Well, unfortunately, that is all the time we have for today. Any other questions that were asked will be passed along to the panelists, so you will get your answers. In closing, please note that our next program on March 11th will cover the winning edge for building the best care team. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week as we cover strategies for advancing your virtual nursing program on our website, healthleadersmedia.com. I want to thank our panelists so much once again for an excellent discussion, and our sponsor, Collette Health, for making today's program possible. And finally, thank you so much in our audience, to those of you watching, for participating. We hope you enjoyed today's program, and we look forward to seeing you during our next program on building the best care team. Thanks, everybody.